underpinning all of that underpinning all of that are the essential principles and best practices that we're, of trauma-informed care, meeting a person where they are and providing the response. I got to get that off there we go. And providing the response that's appropriate with the level of need, right? So with that, we've been also moving towards a data platform that underpins this system and leads us more towards a data-driven system. And still another embarrassing moment, PRS is one of our crisis call centers, but it is NetSmart and BHL that are actually building the platform out. So BHL actually operates a similar system out of Georgia, where there are mobile crisis teams and a crisis call center serving various areas and the ability to dispatch in real time. We've completed the crisis call intake portion as the foundational level of our data platform, and our crisis call centers across the state are currently operating within that platform and able to interact not only with the callers from the National Suicide Prevention Line, but also some of our Marcus Alert local areas, crisis teams built out through our regional hubs. It's a building capacity. And one of the things we think are really going to facilitate that build is going to be the further build out system. But just having the call center in of itself is a pretty important mechanism, because most crisis calls that come to the call center, right, 80% of them are resolved at the point of the call center, which really alleviates the system quite a bit when it is operating and moving on all cylinders. But for that remaining 20%, we would like for them to start getting the mobile response and those other pieces that we were talking about in the build out. And we think a really important mechanism that started in earnest with the configuration today has been the mobile dispatch piece. When an individual is placed, it calls a call center, the call center determines that a mobile dispatch is required. They're placed into a mobile dispatch queue. And in that queue, you're going to be able to see what their disability is, presentation, address, dispatch level, but more importantly, where they are in the process of being responded to. So pre-dispatching would necessitate that no one has been dispatched to them yet. There's arrived, in transit, and assessing. And if you notice, by assessing, we would be able to have a button to initiate a safety check for the mobile crisis response team who is out there. Each one of the individuals who are in crisis would populate as an X on the map. And my apologies, this is the Atlanta map. They pulled this as a wireframe for us. This is what their actual existing map looks like out of Atlanta. And you see X's populate where the individual is in relation to their crisis. The numbers you see there are the mobile teams available for response. For Virginia's build out, those mobile teams, instead of being 6, 15, 12, would actually show the regions they are available to respond to, because we know there's some bleed over between the regions. Say a mobile crisis response team has a designation to be in region 4 and 5, it would be a 4 and 5. It's just 5 that they respond to, it would just be a 5. Once a team is selected, or once the individual is selected off of the map, it would populate every team and their ETA on the adjoining team info page, along with the team type. So if we know that this required a level of specialty related to developmental disability, well, we have an IDD team there that we could deploy that is within reason as far as their ETA. Once they click that team, they have the option to provide a note to the team, maybe information like there's a dog on the scene, the individual is on the 3rd floor of the building, any information to help locate the person or provide security. When they hit the dispatch button, we've now started a clock. In the background, we have point of dispatch to point of acceptance. This would shoot over to the mobile crisis responders mobile app. Each mobile crisis response team is going to be required to have a GPS enabled phone in order to help populate them on the map, and then also to accept the crisis at hand. So again, that background clock's going there. Once they hit accept, we've captured the time from dispatch to acceptance, and we started the clock on transit. Once we have the individual and they have accepted the case, a map populates for them to be able to find the individual. This is generated through Google Maps. They would hit go, and when they get to the scene, they would end up clicking this button that I should be saying arrived, but you caught me with another snafu on here. But it would say arrived, and that would close the loop on our transit time. And the moment they hit arrived, we enter a safety screen, right? So this would be displaying for the dispatcher would remind them of the information related to that the dispatcher put into that notes section at the beginning, and would populate safety buttons such as, look, I need help, law enforcement, medical. We're going to have to build out another button there related to contacting the original dispatcher, just in case you need more information related to the crisis. I can't find the person, or there's something I'm missing here. But we're really excited about that piece. It's, again, the configuration of that has started in earnest today. Our hopes are to be testing it come early April and have it ready for deployment with select teams after that. So that's the biggest update related to crisis and the platform and the continuum right now. We have a number of other items that have been going on with the continued build out of mobile teams, the expansion of some of the mobile teams in the response area. But this is it's a growing continuum, and we're trying to be deliberate and patient. But we think that dispatch piece is really going to offer a great level of functionality. So that is enough rambling from me. I will toss it back to Alexandria.
Sure. Thank you, Bill. Thanks for that overview. I know I've seen that presentation, you keep joking 40 times, but it's a really good overview of what that dispatch process is going to look like. And I know a lot of people have been curious on how we're kind of the technology piece to mobile crisis dispatch and really to the crisis system in general. So up next on our agenda, we are going into the overviews of the local plans, of the initial areas, the overviews of their programs. So I figured we would go in order of region. So Erica, you are going to be up first once I can re-share the presentation. Make sure I'm on the right screen. All right. I don't think I am on the right screen, or at least it's not showing it. Let's see. Okay. Erica, does this look right?
That does look right. And
Okay,
you can just click forward to the next slide. Thanks.
All right, sure.
So I just wanted to remind everybody sort of what our region looks like. We're a 5-county region, and we are a huge geographic region. And we have 12 law enforcement agencies within our catchment area. And the RRCS has clinics only in Culpeper and Fauquier. They've operated a CTAC in Culpeper since 2017, and we're having another CTAC site open sometime in 2022 in Fauquier. The hope had been actually that it would be open right now, but there's been challenges with staffing, particularly in relation to security. So that is, we're kind of stuck there in limbo. And then again, just to give you an idea, they've been training CIT in this area since 2015, and they currently have 275 plus. They just finished a training, so there's going to be plus officers and dispatchers that are working. They've actually trained more, but because of overturn of employees and stuff. And then two things that are really part of the Marcus initiative that have started is the C Center, which is a peer recovery drop-in center, which opened in August. And then the co-response, the mental health co-response program, which began in one locality in July of 2021 and has expanded now across 3 counties. So, and you can flip the screen for me. My executive director always wants me to tell everyone about the comprehensiveness of our local planning group, which didn't seem like a big deal to me at first until I started working with another area. And this planning group that was put together really has folks from all the 5 counties and all the representatives that you would want to have involved, including law enforcement, dispatchers, CSB folks, community advocates, peers, family members of folks, and people that are in their own mental health recovery. So it was a good comprehensive group to work with. And the first thing that they tackled was the voluntary database, and a little bit different than the other folks is they decided they wanted our voluntary database to be available across all 5 counties. And so it's housed within the CSB, and you can flip the screen, Alexandria, thanks. And this is the RAC card that was created by a subcommittee of the planning group, mostly with family and peer specialists working on this to get the language really well formulated. And so this tells a little bit about Marcus Alert, tells a little bit about the voluntary database and how to sign into it. And so this has been out in the community since November. We've had lots of the people on the planning committee making presentations about the voluntary database and to get folks signed into it. And so that's just a little bit of what they've been doing there. So again, it's housed in our CSB cloud or whatever IT thing. And then the PSAPs, they log into it when they come on shift. And their logins are not each day, but who has access as they change over, that's monitored by the PSAP supervisors. All right, so you can flip for me. This is kind of where our responses are right now. I was listening with excitement about hearing about mobile crisis because we don't have it available to us right now. So our response levels are a little bit different than what we're seeing everywhere else, I think. In our level 1 response, we're coordinating with the crisis call center, the PRS, the PSAPs are sending them directly over there, and that's been working out pretty well. Level 2, they're connecting with the regional call center as well. But the PSAPs, in coordination with them, they might dispatch our mental health co-responder, who they always go with a CIT officer. So, and so that's where our level 2 response is. Level 3 response is we're dispatching our mental health co-responder and a CIT officer. The mental health co-responders are not on 24/7, so sometimes it'll just be a CIT officer. And then the same things are happening with level 4, but the officer is taking the lead. So that is where our responses are currently. You can switch the slide for me. So in January 2020, this last month, January, our Marcus coded calls, all of our counties indicated that the Marcus coded calls are less than 1% of their call volume. And they were about 40% of the calls were transferred to the crisis call center. So level 1 or level 2, and 60% were responded to by co-response. Some of the level 1 and level 2 calls are being responded to by co-response and law enforcement, or if they're after hours, they would be, it would just be law enforcement. Because the caller was requesting face-to-face, and that was something that our area decided that if a caller is requesting a face-to-face interaction, then we're going to send it no matter what the call was coded. And then also too, the other thing that is happening is for if any calls that are responded to outside of co-response, co-response follows up with those calls the next day. And then also to our level 1 and level 2 calls are being referred to our C Peer Recovery Center as well. And I'll tell you more about that later on. You can flip it, thanks. So the way that the mental health co-response program looks at Rappahannock is we currently have a clinical supervisor, 2 clinicians, 2 peer recovery specialists, and 1 QMHP level clinician. And so the program began in July 2021. It was, we had a clinician in the Culpeper PD and we had a clinician in the Fauquier Sheriff's Office. And over time, things have expanded to add the peer recovery specialist and the QMHP. And so the Culpeper PD co-responder who's at the Culpeper PD, they'll respond to the Culpeper County as well. And then the Fauquier Sheriff responds to Warrenton PD and Rappahannock County. It's expanded into Madison County as of December 2021, and they plan to expand to Orange County. And they're studying their data to determine the best hours of coverage. So you can flip. And this is just the data that's come out of our co-response program. And again, looking at this, they have decided to change some of the coverage hours, particularly in Madison and Culpeper. And so you can flip again, so we can get to the C Center. The C Center is our peer recovery center, and it's a peer-led drop-in recovery center that's open to the entire community. The hours are Monday through Friday, the full day pretty much, and then Saturdays 9 to 5 and Sundays 4 to 8. It's a living room model. They have a bunch of different sensory rooms, and the big important pieces is there's no barriers because there's no cost for services. And you can keep flipping. And they offer a variety of services in groups, and keep flipping. I have my time check. And so they have, over February, not today, I pulled this morning, they've had 781 visits. 80% of those folks had visited before, 20% it was their first visit. And then the breakdown of the counties that they're coming from, and then the breakdowns of their gender identity. And then the last thing I wanted to flip to is just to let folks know that Rappahannock area is starting their project, and they're starting to work on the nuts and bolts of Protocol 1, and they have concern about legislative changes. So that's where we're at.
Perfect. Thank you so much, Erica. And you have such good information. I'm sorry to give you a time check, but I did jam pack our agenda today. We have so much information to cover. It's been 6 months. A lot has happened since the last time we were all able to get together. So I know it doesn't leave a lot of opportunity for questions also. So if you want to put any questions that are lingering in the chat, I think our speakers will be happy to answer some of those questions for you all. And we'll go ahead and get started on our Region 2 update. And I think Elise is with us to go ahead and give that.
Hi, yes, I'm here. I am standing in for Heather Baxter from Prince William Community Services. And if you just want to go to the next screen. So in Greater Prince William County, our Marcus Implementation Work Group has been meeting weekly for 6 months. It seems like a lot longer than that. And meeting bi-weekly for the past 4 months. And the stakeholders that are included in that group are us, the CSB, Fire and Rescue, the PSAPs, police, the magistrate, chief magistrate, our local hospitals, our regional projects office, and our regional mobile response. You can go to the next slide. Greater Prince William Community Mission Group, which is another group that we created, has met monthly with the following goals. The first was to develop a marketing approach for educating the community, to develop tools for reaching diverse communities, and to obtain community feedback regarding our Marcus Alert plan. You can go to the next screen. We have created community care teams. Our co-responder team was already up and going prior to Marcus Alert legislation. So we were lucky in that our county had already funded the first three of our 6 teams. So currently we have 6 teams with Prince William County Police that are active. We have just recently gotten our outreach and engagement team hired. We have 3 clinicians and 1 peer. 2 clinicians have been hired and will start responding March 14th, and we are working on our other 2 hires. Our regional 24/7 mobile response is provided by outside stakeholders through REACH, CO2, and One Life, One Love, which is a new provider in the Northern Virginia region. And that contract is in process and we hope to launch by April. They came to our mobile crisis meeting, regional mobile crisis meeting last week, and they're very excited to get on board and said that they have the ability to hire more teams, but they plan to have 3 teams ready once their contract is started with us. Can you go to the next slide? Our voluntary database, that has been started and they've been operational since July 1st, 2021. We do have 3 separate ones because in Prince William County, we have Prince William County proper, Manassas City, and Manassas Park. Prince William County has Smart 911, Manassas City has Rapid SOS, and Manassas Park has Smart 911. We've created all the informational cards and flyers, and they've all been distributed to the community, police, fire and rescue, our emergency services, and our CSB partners have also been handing them out. Next slide. Okay, and this is just kind of our timeline. From November 1st, 2021, the training of the PSAP and PD began. January 1st, our regional call center vendor was identified, and that call center vendor is PRS. March 2nd, the training for, this is coming up, but the training for PD and PSAP completed. What did I feel like I didn't create this, Heather created it. So December 1st, PSAPs and PD began tracking Marcus Alert triage levels. PSAPs began utilizing triage cards. And then the MOU has been finalized and is awaiting signatures by all of our stakeholders currently. The next slide. Okay, the things that are pending, spring 2022, we are waiting for our crisis call center to be operational. We're really excited about that. 911 will be able to transfer level 1 and level 2 calls to call center. The regional behavioral health responses will be dispatched. And by July 2022, 988 will be operational.
Perfect. Thank you so much, Elise, for giving that update.
You're welcome.
Again, if anybody has any questions, feel free to drop them in the chat, and Elise should be able to answer those for you. I know there are some other questions. Thanks, Lisa, for kind of fielding those questions. And I seen some chat about like the legislation that's specific to Marcus Alert, so that we will be covering that at the end. Josie from our legislative affairs team will be giving an update on those, so she can provide a lot more kind of those details from the legislative perspective on that. So we do have that on the agenda to talk specifically about that. So up next, Byron from Highlands will be giving an overview of their program.
Okay, go ahead. First off, I'll start by telling you that we are probably one of the smaller CSB area regions, or at least CSBs in the state, having only Washington County and the city of Bristol that we encompass. It's about 600 square miles. We have 9 law enforcement agencies that we're partnered with. I saw Patrick on there, and I'll give him a shout out. With the help of New River Valley, we stood up a CTAC in 2019 and began our CIT training program in earnest at the local law enforcement academy with a lot of their help. In a couple of weeks, though, we will be growing quite a bit. Our CTAC program will be going 24 hours, and it will be combined with a 23-hour step-down unit or the living room model, as well as an overnight CSU in a comprehensive crisis services center. So we're excited about that, and we're undergoing a lot of growth right now with our programs. To get right into our Marcus Alert program, I'll talk to you a little bit about our complex stakeholder MOU. We've got multiple stakeholders, as you all do as well, but we are incorporating multi-jurisdictional co-response. Because we are a little more rural than some, we are going to be operating mostly out of Washington County, but our county deputies will have the ability to partner with and answer calls in the city of Bristol as well, which is a pretty unique approach, and we've worked hard on this MOU. The MOU itself is pushing 20 pages, and for those of you that are used to doing MOUs, when you get over 2 or 3, you can get pretty complicated. So everything we have is ready to go. We have our call center online. We are up and ready to go with New River Valley as well as for our mobile crisis piece. And in our MOU, there's an in-depth policy and procedure for just about every aspect of what we're doing. And I'm sure it'll provide Chris a good template to take to the other CSBs in the region. As far as our regional Marcus Alert training, we started that last July in earnest as well. We have since 2019 been offering an intro to CIT for all of our basic law enforcement academy classes, 2 and sometimes 3 classes a year. And what we do, we spend a day basically covering some CIT concepts just to familiarize them with what CIT is and some things about the mental health system to increase their awareness and their familiarization. So what we did, we combined and included a large piece about the Marcus Alert program. So these new officers that go out in the field are already familiar with what the Marcus Alert Initiative is, how it started, and how it's going to be beneficial to not only them, but the public. And we're also going around to individual agencies and within our catchment area and training them on the different things we'll be doing as well. So the next slide, I'm really excited about. Our CAD software provider with our main PSAP has approved basically all of our Marcus Alert triage levels, and they have created an EMD or emergency medical dispatch. I'll get Chris to talk a little bit that in a minute because he's got quite a bit of experience as a dispatcher. A series of easy ask questions for the dispatchers to be able to triage the calls. I hope I'm saying all this right, Chris. If I'm not, you can correct me in a minute. But if you want to go to the next slide, you'll see our triage levels. And when you look at them, you'll see that they may be overthought a little bit, but we tried to include just about every situation we could think of. Sometimes that can be good, sometimes bad, but it's worked out with us. We've worked very hard with our stakeholders on this. So if you go into the next set of slides, you'll see the questions that our dispatchers now have at their access on their computer screens to help triage these calls to be able to dispatch our co-response units. What will our co-response units will consist of? We've got 2 law enforcement officers that will be partnered with 2 clinicians. They'll be working a 12 to 12 shift. Like I said, they can operate in either of the jurisdictions, either in the county or the city, and we'll also have 1 peer assigned to them Monday through Friday. So we're really excited about getting this up and going. I know we are a little bit behind the December 1st deadline, but we've taken some extra pains to make sure we get all of these bullet points answered, I guess, before we go into something without being prepared. Chris, do you want to talk a little bit about some of these levels and how they work?
I'll just kind of tell them what the EMD is, and that is very exciting. By the way, this is my 4th day on the job, so happy to be here. Probably don't have as much information today as I hopefully will next time we meet. But the EMD, the emergency medical dispatch, it's basically just a uniform way of answering these medical type calls. And when somebody calls dispatch, they're going to, if they call, a consumer calls and says, hey, I'd like to hurt myself. Well, that's going to be put in, and then a series of questions are going to be brought up for that dispatcher to ask that person. Are there weapons? Are there not weapons? And then based on that, other questions will be asked, and from there, the appropriate resources in a more timely and efficiently manner can be dispatched. So very exciting. And Byron has worked his tail off getting that done. So, and we have a great PSAP coordinator who also has been very supportive.
Yeah, and I will add that the CAD provider for our main PSAP did this free of charge. So I was really excited for that. They had a lot of buy-in to this. So as you all know, dispatchers have enough on them as it is, and anytime you can simplify their job, it makes it a lot better. We're really excited to get this point. We should be up and running with all of our signatures before the end of the month, and look forward to getting data and providing these services to the community. Sorry, I didn't have a lot more, but I was afraid I'd go too far over my time. I can be a little too chatty at times.
Thank you. This was a really good update, and you did tell me you were going to go long. So this you did not. I was prepared to give you a time check. But one thing that you touched on a little bit that I wanted to see if you can elaborate on is your Marcus Alert training that you're providing. So I know I've talked to you a bunch about it, and you've given a little bit of a demo, but you talked about it being as a part of the Intro to CIT course, but I know this group has had some education, and some people in the group are really familiar with CIT, but can you talk about like the level of the officers who are going through that intro course, just providing a little bit more detail, because it's been a while since we've been refreshed on CIT, about them not being like, it's not, or it's recommended that they wait a year or two before they actually go through formal CIT. So this is kind of in the basic when they're first getting going. Does that make sense? And if you can provide more of those details around it.
We do that. It's a one-day class, and we do that in each basic law enforcement officer academy. These basic recruits are getting a lot thrown at them. And I can tell you, when I went through basic back in 2001, I had about 4 hours of mental health training, which is sad, considering the amount of times I dealt with people in mental health crisis. Our local academy has increased that to an entire week. They're dealing with different parts, different facets, the code section, because we all know what hurts people a lot of times is ignorance or lack of knowledge, and they become fearful and they can't do their job correctly. So the academy does a good job. I would say that they will increase that because everybody that goes through the academy not only gets intro to CIT, they also get mental health first aid, a lot of code updates and things of that nature. So what we do, we tell them what CIT is, because they're going to hear those 3 letters when they go out into the field. We give them a brief overview of the 4 coaching plays, a little bit of background, and we tell them, hey, you know what? When you're going into these situations, be very careful about putting yourself in an officer-induced jeopardy situation. What I mean by that is an officer who is a little too egregious and puts himself in a life or death situation, when if you use common sense and use a little bit of foresight, you can avoid that. I preach on that a lot during that day. I agree with my CIT coalition comrades that the CIT basic probably shouldn't be taught in the basic academy. It needs to be taught after you have a little bit of life experience. However, they need to know what it is, and they need to know at least some background and fundamentals about it. So that's what we do. And it's been very successful. We've had a lot of people come through training, our CIT training, after they've gotten out of the academy about a year later. And they said, everything you're saying is correct, and they fully buy into the process.
Thank you for that. And as noted in the chat, these EMD cards are really, really great. So thank you for sharing those with us too. All right, well, I will move on to next. So next, John Lindstrom from RBHA is going to be providing us an update on Richmond John, are you ready?
Sure, Alexandria, and thank you. I am a last minute substitute, so I have some notes to share. I do not have slides to walk you through that, but by way of a little background, to tell you about the city in reference to Marcus Alert, the city of Richmond, and RBHA in the context of Region 4 programs and services. We initiated Marcus Alert planning prior to the Marcus Alert legislation. And so for a period of about a year, we didn't make a lot of progress other than to kind of establish what we thought might be the appropriate parameters for a Marcus Alert plan prior to the legislation. Then once the legislation passed, and looking at the details of the legislation and the pending state stakeholders group, we made sure that we had representatives in that and followed along week by week, I think for 10 sessions in that process. Since that time, our local Marcus Alert planning team has been expanded, and it continues to be expanded as we add other pieces to the process. We truly look at the December 1 launch of Marcus Alert, which we were able to do successfully, as a soft launch, but one that requires the use of a learning model so that we can tweak and amend that as we gain experience with how it really works, the parts that are working well and the parts that need to be redressed in some way. The Richmond Behavioral Health Authority, as the principal partner with Region 4 in delivering the whole array of crisis expansion services for Region 4, has been involved with CIT since around 2008. I think it was right on the heels of Henrico launching their very significant training initiative next door to us. We operate a CTAC, or a crisis CIT assessment center at Richmond Community Hospital. We operate an adult crisis stabilization unit located in downtown Richmond, and have a contract with St. Joseph's Villa for a residential crisis stabilization unit. We're employing all of the staff for the Region 4 build out of mobile crisis. And to date, we have finally gotten some traction on the adult side. We only have 3 positions to yet fill. And on the child side, which has been operating a longer period of time, we are down to 1 vacancy in that. So we hope to be able to soon deliver mobile crisis 24/7 across all of Region 4, but more concentration, obviously, because of population density in the Richmond, Henrico, and Chesterfield areas. We also have the REACH program that we operate, and the mobile crisis dimension of REACH is integrated with our mobile hub. So there are REACH specialists that have specific crisis skills for individuals with intellectual and developmental disabilities. And we are currently operating our own hub line as a way of facilitating dispatch along with PRS, our call center operator, until the full data platform is wholly functional. And we're really looking forward to that as an air traffic control system. As part of that process, we are also continuing to meet every other week as a Marcus Alert local implementation team. And we are currently planning our first of the 2 annual stakeholder meetings that follow the 4 that we held during the planning year. And that meeting will probably occur at the end of March, early to mid-April. And we are hoping that's going to be a live event. We're currently scrubbing our initial stakeholders list, which was around 50 people, to see who really participated and see if we can't fill in other enthusiastic community members to make sure that all portions of the population are represented. Richmond City has 1 PSAP, or Emergency Communications Department, and it only dispatches for Richmond City Police, Fire, and Ambulance. So part of our process will be, after we have all of the kinks worked out in that system, how do we bring other major law enforcement entities that operate within the city on board, and to give them use of those assets. And that would include the VCU police, which is probably the second largest police department in the city, along with other university and community college, law enforcement, and the Capitol Police. But they all have their own dispatch systems. And so, and they don't operate like the typical PSAP. So it's going to be a bit of a challenge to do that, but we have willing partners to help us solve that problem. As like all the other communities, we devised just about the same criteria for Marcus Alert levels 1, 2, 3, and 4. What we've been examining early data from the regional call center as well as our PSAP in terms of call volume and the way those calls are being coded. We don't recognize as high a level of alignment in the data between the regional call center and the PSAP that we would like to see, but we are working on that, and we think we're getting zeroed in on the kinds of things to help improve the agreement and data between the two. But to give you an example of the Richmond call center, during the month of January, they coded only 19 of the calls to 911 as level 1 or 2 under Marcus Alert, which would be the warm handoff to the regional call center. They coded 83 calls to level 4, which was immediate public safety dispatch, police dispatch. But a very large number, 445, were coded as Marcus Alert level 3. And that gives us a lot of opportunity to work in both directions on that, to determine how can we tweak our screening protocol to cast more of those calls into level 1 or 2, or simply pass off to the call center, or how we can respond to them using our co-response model. And the co-response model that we're developing in Richmond, we have finally identified 2 officers, and we've hired the clinicians for that team. We've also hired an additional case manager and a QMHB, and we're in recruitment for the peer to be a member of that team. We've located them in a non-police location. They'll be operating out of Richmond Behavioral Health in our administrative office at 420 East Carey Street. We've ordered the office equipment and furnishings for them, and we're waiting on them, but we expect to put them all under training during the month of March and hope to go live with our co-response team April 1st. And they will be using soft uniforms. They will be using alternate transportation. They will also be going through not only the basic trainings for our agency and law enforcement, but we will be adding to that, as it's available, the Marcus Alert trainings that the department is contracting for as well. We do plan on them doing some ride-along and field training with Prince William. We've had a good relationship, and they've been very willing to share information with us, and they have a much more mature team and process there, so we're looking forward to that. We've also met with the 2 providers who received grants under the Equity at Intercept Zero. So we've met with Dr. Atasha Christian, and now we've included her on our stakeholders group. And she's attending our biweekly Marcus Alert planning meetings. Atasha's agency, Guided Pathways, will be a BIPOC provider that will be available to participate in the response process. And she's already willingly picked up the mantle on helping us do some training. Her agency was represented in our most recent cadre of individuals that went through the child crisis response training. And she will be helping our team train private providers as they come on board, as well as CSB staff. And we've met with Chantel Hammonds of Peter's Place, and she has a funded proposal under Equity Intercept Zero to focus on the development of training and consultation around the LGBTQ plus community and the special needs that they may present in crisis. We plan a providers meeting in the spring. We're awaiting the finalization of the MOUs between private providers and the regional hubs. And we hope to be able to move forward with contracting with them so that by the time the call center has the data platform fully functional and able to handle that air traffic control function, it won't just be our publicly employed mobile hub that can respond, but the private providers who meet the qualifications and have contracted under that MOU. Finally, I'll just tell you, I've heard a number of people mention the importance of data and the dispatch aids with the call center, with the emergency communication centers or PSAPs. We have a RFP, our DEC, our Department of Emergency Communications, has a RFP pending with the city attorney's office review to release for reprogramming its CAD to include the kinds of screening questions and data development and retrieval that you've heard others mention of in this meeting. So I appreciate the time, and if there's any questions directed to me, put them in chat or ask them now.
Thank you, John, for that update. And we are looking really good with time too. So we might have a little bit of, after Todd's presentation, opportunity for some live questions.
Alexandria, there's one thing I failed to mention. It was a little deeper in my notes, but
okay.
My colleagues and partners in Region 4 are not letting any moss grow. And even though I know that there were some issues with pending legislation about timing of rollouts and adoption, I want you to know that Henrico CSB, which would be the next one up for Marcus Alert implementation, is multi-jurisdictional. While our implementation is single jurisdictional for the city of Richmond, we have employed the Marcus Alert liaison, and we are already interfacing with Henrico. Henrico is holding regular meetings with a core group of departmental staff, mental health, emergency services, police and fire, and CIT to begin their early Marcus Alert implementation planning. And Chesterfield CSB is also in maybe earlier stages of Marcus Alert planning, having identified a broad buy-in from the county leadership for Marcus Alert and started discussions with their police department and their PSAP. So anyway, and regional police departments are convening monthly at the Henrico PD Training Center to discuss related matters around mental health, including ECOs and TDOs, and to incorporate any updates around the Marcus Alert development into their discussions.
Sounds good. Great. Thank you for the regional update too. So next I'll move us to Region 5, which is Virginia Beach. So Todd, are you ready?
Yes, ma'am. Can you hear me?
Yes.
Okay, good. There should be some kind of signal for that kind of stuff. Okay. I'm Todd McGee. I'm Region 5 Marcus Alert Coordinator. Basically stationed out of Virginia Beach and assisting with the implementation there. Next slide, please. So this is an overview of our vision statement. We want to foster wellness in the community through a range of services that's sensitive to the individual cultures, respectful of their trauma. We put this vision statement basically at the forefront of how we're setting up these teams. We want to utilize well-trained and competent professionals who respond with empathy to behavioral health emergencies while treating everyone with unconditional respect and dignity. We want to link individuals with appropriate resources while achieving safe and desirable outcomes in the city. So we have a big push with our training with our team members to maintain that empathic response when we're responding to individuals in crisis into the community. Next, please. And of course, everybody knows we've gone live since December 1st. We've been collaborating with Virginia Beach Department of Human Services, Emergency Communications and Citizen Services, PD and community stakeholders. We started to integrate with our emergency medical services Now, we're going to start ride-alongs with some of our staff to try to see how that works out to implement EMS into our co-response team here in Virginia Beach. Next, please. And this is basically a state-level overview of the components. Everybody is familiar with the 4-level urgency triage framework. We're still working on the development of our mobile response and crisis teams. We're waiting on, of course, the federal 988 implementation. We are focused on statewide equity intercept zero initiative and doing what we can to have mental health response replace as much as possible what law enforcement is normally doing right now. And of course, we're waiting on the statewide training standards and the public service campaign. Next, please. Everybody's familiar with the different levels of response that we have. Right now, we have our level 2 response. We have 2 specific teams. We have one located in Wichita, which is sort of central, maybe a little western Virginia Beach, that's responding to level 2. And of course, we have our co-response team that handles the level 3 responses, and they're over off of Magic Hollow, which is the Lynn Haven area, which is pretty centrally located for Virginia Beach. And of course, law enforcement responds to the level 4. Next, please. So this is an overview of our mobile response teams. Right now, we don't have 24-hour coverage. We're operating from 9:30 to 10:30 p.m. We basically have 2 teams that overlap throughout the day. Of course, law enforcement's not involved in these particular calls. We have been really successful with a 1-hour response time or less in Virginia Beach. In fact, we've responded. Our first call was to Norfolk, and we were there in 17 minutes. And obeying all traffic laws at all times. I just want to specify that. I had to add that. And of course, in our dispatching from the regional call center for the level 2, any kind of law enforcement requests will be prioritized. Next, please. Our co-response team, like I said, is located in a different place, and that's connected very heavily with our crisis services, our emergency services, and our CTAC. So these are individuals that are ES certified pre-admission screening clinicians, along with the law enforcement officer, that are dispatched directly from our PSAP. And this basically gives us 2 options on scene. If there is a need for a emergency custody order for the individual that's in crisis, then we have our law enforcement individual there, an officer there, and then of course, to save as much time as possible, that emergency pre-screener located with them so they can provide that pre-screen if required to determine what kind of treatment response is needed for the individual in crisis. We are using peers and behavioral crisis clinicians that are doing follow-ups. That's one of the big issues that we're really excited about here in Virginia Beach is that, we're using the mobile response team the way Marcus Alert's designed to try to reduce the number of calls that law enforcement is responding to. But we're also trying to eliminate that situation where in the past, individuals that were in crisis, once it's resolved, they're de-escalated, they're usually handed a piece of paper, a card with a phone number on it, and then left to their own devices to ensure that they're going to follow up on that referral. And we all know, being in the mental health field, that that's usually 50% effective. So we work really hard to maintain that warm handoff, and the individuals that are responding to these crises are getting the individual into services and connected with someone else if services are required or whatever that resource is on the scene in real time, and ensuring that they are getting connected. Our peer and behavioral crisis technicians go out to follow up to make sure that that the individual that was in crisis had a successful evolution with dealing with their issues, and also assisting to any kind of connection to any kind of follow-up services that they may need. Next, please. This is our 988, our regional call center. Of course, 988 is working with cell. This is our local number that we have because, as everybody knows, with cells, there's no geolocation right now for 988. So unfortunately, with the national suicide prevention lifeline, everything's sort of coordinated by the area code, and this being a very intense military community and also with colleges, very few people actually have 757 area code. So there is a direct call-in line for, as you can see, for the landlines, and to maintain that local connection to the regional call hub. And that's managed out of Western Tidewater, CSB, and they assist with Virginia Beach, Norfolk, or connect with Virginia Beach, Norfolk, and Eastern Shore. Next, please. So since we went live, this is basically our numbers right now. We're still calculating this out, but our calls are averaging a little over 1,000 per month just using the Marcus Alert system. And that's between NPS, National Suicide Prevention Lifeline, what's coming into 911 and being rerouted to the call center, and what's coming directly to the call center. So you can see from the numbers that calls diverted directly from the 911 line to 988. It was roughly 80 in December and 43 in January. And then with our co-response team, which would be our level 3s, we had 70 of those calls. So that would be coming straight from the PSAP, getting our co-response team, and 70 in December and 27 in January. I don't have February's numbers yet. One more day. Next, please. And we put this out. The equity at Intercept 0 is very important, and we're making sure that we get people that are dealing with mental illness and substance use disorders, that they're not being charged with an offense, that we're getting mental health involved. We put this information out, and we continue to reinforce it, that the purpose of the Marcus Alert system is try to reduce that law enforcement involvement and assist individuals that are in crisis dealing with serious mental illness, that are getting into some kind of treatment and some kind of assistance. Next slide, please. And this, everybody knows, I wasn't sure what was going to be gone over before I came up, but we are waiting on trainings, and we know DBHDS is working on that for standardized training throughout the state. Next. And this is just basically an overview. We stress this, the importance of calling, especially with the importance of calling early in a crisis. That's another thing that our response teams are coordinating with the individuals that are in crisis. Once they de-escalate the individual in the system in any capacity possible, we stress the importance of continuing to call 988 rather than 911, and also trying to obtain assistance as early as possible before some of these situations escalate to the degree that they need a higher level of care. And that, once again, is an overview of our different levels of triage. And I think that's a wrap. Next slide, please. You all right? Any questions? That's all I got, Alexandria. Thank you.
Thanks, Todd, for the overview. Thank you for putting this slide together. Yeah, and I'm not sure if you all, I haven't checked in with Dr. Hawks to see if you all have been able to connect. She is the Region 5 Equity at Intercept 0 project. If not, I will make that connection between the two of you all, so that you are aware of each other and you can have those talks. So,
Excellent.
oh, it looks like
Thanks,
Lisa.
Alexandria.
It looks like Lisa dropped a question for you in the chat too. She might be putting you on the spot, Todd. Do you have any thoughts on the higher numbers in December versus January for the calls that you all received?
Yeah, as a mental health professional, I could theorize that, December is a very hectic month, and that's all that I can see. I could make a joke that, once everybody got their Christmas presents, they were less in crisis in January than they were in December. But honestly, in my experience, I've been working with CSBs for coming up on 20 years. The time leading up to the holidays is definitely hectic for everyone. I can see a lot of people being in crisis, and a lot of people have unfortunately anniversary dates to trauma connected to those particular holidays. So that would be my guess. That's just a guess based on my experience.
Yeah, I think that's really interesting. And I also think about like the holidays and being in a high military area too. I wonder what the impact of being away from family, that kind of isolation that you get, what that could have. I was also really surprised to see the number or the volume of calls that seem to be coming directly into your crisis line versus kind of the PSAP transfer. So it's good to see that you all are being that you're able to get 988 and also your local number out there and have folks know that they have a way to get in touch with the crisis lines and a place to call for help in Virginia Beach or in your region. So thank you for providing that overview. Looking at the time, so we have about 5 minutes before our presentation from Dr. Sarah Vinson. So I wanted to go ahead and I'll stop sharing now and see if there are any questions that anyone has about the presentation that we just, or any of the presentations that we just had. We do have, again, a legislative update and also, I think, yeah, just the legislative update kind of after Dr. Vinson's talk to go over, and that'll talk about Senate Bill 361 and House Bill 1191. So we'll get more information on that. But were there any, in these 5 minutes, any questions or comments or anything that anyone wanted to provide?
I'm going to go ahead. I'm Karen Gill. This is the first time that I participated in the statewide Marcus Alert meeting, but I've been participating in the planning for the Richmond, and I'm leading our public relations efforts. So I wanted to ask Mr. McGehee, is that the pronunciation correct? If I know I've talked to someone previously from Virginia Beach about your public relations efforts, but I was wondering if you had any other information about if you had a strategic plan or any materials that you have shared with the public so far that you would be able to share with me or with the group.
I could definitely, it's just McGee, but you can call me Todd.
Okay.
We don't have any advertising. We're in the process of working on that right now for getting some kind of local advertising involved, but I can give you my contact information. I've been basically, I'm former military and very connected with the bases around here. I previously worked at Fleet and Family, so I'm working with their exceptional family member program that deals with special needs and stuff like that. So it's been sort of a personal thing to get out the information to individuals that are working large programs for the area. And I'm wide open. I can give you a copy of our overall presentation. NAMI has a copy of our overview presentation, which is a little bit, it's basically the same thing what you saw, but a little bit more detailed. I stripped out some things that I thought would be redundant for the state. But I can share and put you on a mailing list that's any information that I'm providing in Region 5 can go out to anybody.
That would be great. Thank you so much.
No problem, man.
I would just add, Karen has worked with us since we formed our official local implementation team. She's employed by DEC and she is their public information expert. And she worked with us on developing our campaign around the voluntary database. And we use other city agencies to put out printed cards to encourage individuals to enroll in that. And she will also be working with us, hopefully in concert to whatever the state's going to do on promoting the 988 system. She'll be working with us on creating public information materials that we're posting, by the way, in Richmond on the city website, as well as the RBHA site, all the city agency sites that we can get links on, and the Richmond Black Lives Matter organization. So Karen, I would have introduced you had I realized you were there.
Oh, no problem. I just jumped on a few minutes ago.
Sure. So thank you for the introductions, John and Todd. If you, I don't know if you already did, but if you want to drop your email address in the chat for her to have your contact information. we're also recording this meeting, so I did put the all of the regional coordinators in the presentation, so you will be able to find their contact information, and I put the different DBHDS regions that they're connected to. So I'm looking for our next speaker, but I'm not sure if she's with us just yet. So I think it might be a good time, Josie, if would it be okay for you to start talking about the legislation? I know we had a time slot, but are you ready?
Sure, I can talk about
Okay,
it.
thank you. I appreciate that.
All right, so I know there are probably a lot of questions about these, but I'm just going to kind of try to go over what each bill does, and then I'm happy to take questions. I know Chloe was pointing out in the chat some of the intricacies of these bills. So SB 361, that is Senator Stewart's bill. That one, the current substitute of that, it would delay the implementation of Marcus Alert protocols for anyone with a population over 40,000 to July 1 of 2023. Anyone with a population under 40,000, it would be July 1, 2024. It would also require an annual report, any work group to identify barriers to implementation for all localities. I want to note that the administration did support this bill being amended in this way to have these deadlines and everything, because originally it was just going to make it optional. It also delays the deadline for the first 5 programs to be in place till July 1 of 23, and the second set of 5 till July 1, 2024. So that's SB 361. HB 1191, a substitute was recently put in so it doesn't do what the Stewart bill does. It delays the requirement for a voluntary database to July 1 of 2023, removes the implementation date for Marcus Alert protocols. If you look at the bill, I'm unclear why the population thresholds are still mentioned there. So I think that's something we're going to have to investigate a little bit. And for HB 1191, you would still have to have the 911 diversion protocols in place. However, the bill doesn't, like I say, put a date on implementation for all of the protocols. And unfortunately, this one has now passed the Senate. So there's that. It will now go to the governor's desk for signing. So I know that's a lot of information, and I just wanted to pause and see if anyone had any questions.
Could I ask for clarification? I'm trying to, is it on the Senate side that exempts as far as the population size to, I want to say it was if they supersede a population then 80,000 versus the House, which makes it optional if localities supersede a population of 40,000. And did I get that right?
So they're actually both at 40,000 now.
Okay.
Yeah. SB 361 is the one that will make it so 2023 is for a population over 40,000, and 2024 would be anyone under 40,000.
Okay, that's helpful.
Yeah.
Okay, so there's little details really to be reconciled between the two versions in the House or the Senate, but saw they both have passed.
Yeah, I haven't seen on LIS, but this doesn't mean anything that the Senate version has gone and passed the House yet. I know it reported out of committee. So as of right now, at least, both are still in play. Lisa, I see your question. But the House Bill 1191 has passed both houses. So again, that will go to the governor's desk for him to sign, amend, or veto.
The other may not pass. I mean, it may not have officially passed yet, but I know it will.
Yeah,
likely pass. But thank you. That's helpful.
Yeah, of course.
Yes, please ask questions. So I originally I've prepared slides to kind of give an overview, but because things change so rapidly, my slides were out of date by the time this meeting was getting started. So Josie kindly offered to give the update on the changes in legislation. I know that for some of us that aren't regularly working with General Assembly, it can be a little confusing about the stages. If it's helpful, that the General Assembly has like infographics for, usually these are for children, but they're actually really helpful for me, that are kind of like the Schoolhouse Rock type of legislative thing. So it tells you like the different stages, but it also talks about like the crossover that happened. So a bill that is titled like House Bill 1191, it's originated in the House, but as of maybe last week or the week before, once it passes through the House, it crosses over to the Senate. And so the senators get to review it, and then they decide if they are going to pass it as well, and vice versa. It starts for Senate bills, they start in Senate, they cross over to the House and they approve them and such. So yeah, and then once bills are agreed upon, then once General Assembly session convenes, which I believe is March 12th, Josie, if that's wrong, if you know off the top of your head, please correct me. Then there's about a month period for they go to the governor's desk, and the governor he has the option to take action, whether he signs it into law. That's where they can veto something, or there's no action that can be taken. But my understanding is that rarely happens, and if the governor chooses to take no action, then it still gets signed into law. But if you want more information on kind of that process, those infographics are very helpful. And if I find the links again, I can send those out. But obviously these bills, it kind of leaves us in a place of trying to figure out exactly, what future implementation of Marcus Alert is going to look like. And so we're just waiting for the process to work out here at the state level, and it's going to impact the guidance that we're able to provide to the next areas on implementation and on the dates and such. So again, if there are any questions you have, Josie is the expert in this field, so this is the prime time to ask away.
So Alexandria, I had a question, but you began to tap on it. It was, okay, what is the impact of the legislation on the future for Marcus Alert in terms of the other areas? So you began to tap on that or to touch on that. So I guess I would say, if you had your druthers and you could have put dates on this, would you have wanted it to be just, what date would you have wanted to be on it versus what is going forward?
So you're asking me directly, right, Lori?
Yeah, I'm just asking in terms of, I guess from the state's perspective, would you have wanted for this to pass with just no dates or just saying immediate implementation? Is that what you would have wanted? Because I'm new to the process, so I'm trying to understand. Well, yeah. July 2023 is just a year and a half or so away.
Yes. So we're at the state level, we're like in a unique position, right? So we at DBHDS and also DCJS, we are executive branch committees. Or agencies, I'm sorry. So we are members of the executive branch. So we don't really get to have an opinion necessarily on the laws themselves. We're just tasked with the implementation of the laws. So a lot of that advocacy work, it's groups like this where kind of that decision making can take place. Well, not within this group, because obviously it's led by the state agencies too, but here we can be in these groups of stakeholders where you guys know like what's best for your local communities and can advocate in ways that we're not able to do so for what makes sense for your local areas. And I hope that makes sense. And
let me maybe rephrase the question.
Okay.
That probably wasn't a fair way of asking the question.
Okay.
So I think that you were beginning to comment on that the future implementation of Marcus Alert is impacted by the current legislation and what is passed. Is there an impact to what's already happening? What's already in play?
Okay, I understand that. So yeah, so the impact so far, what we're seeing in the pending legislation, there first is the voluntary databases. I think both of them address the voluntary database, by moving the date back, it was required July 1st, 2021 initially, and it's been pushed back to July 1st of 2023. I believe that's in both bills. So that affects current, the current implementation. Also, the bills do include talking about like the first 5 initial area pilot sites, requiring like the full implementation of Marcus Alert to not take place until 2023. And then I know Josie kind of talked about the 40,000 population. So currently, as the law stands, population doesn't really have a role in it as far as like the dates or who's doing it. Somewhat it does actually, where the next 5 areas, it's population based. So it's like the larger counties, like Fairfax is up next, right? Fairfax Falls Church. But now it's looking at the specifics of the numbers and saying like, if you have less than 40,000 people, and it kind of bulks them together on the dates. So if it's optional, like that has a big impact for smaller communities. If it's optional for them to participate, then yes, like as the law stands currently, it's required for everyone. And so there's a big impact there.
Very helpful. Thank you.
Okay,
Yeah,
all right.
That's very helpful. It just helps me as I'm learning more about the process. And thank you all for indulging me because I'm newer to the process.
Yeah, of course. And you can always reach out to me for more information. It looks like Dr. Vincent has joined us, so I don't want to pull away from the time that we have her here. And then we do have some extra time after Dr. Vincent's presentation if anybody had any additional questions when it comes to the legislation. So if you want to think about that over the next 30 minutes. So hi, Dr. Vincent, thank you for joining us. If you have a presentation, if you would like to go ahead and share your presentation, and then you can take it away. And you're on mute right now.
Sorry. I didn't have slides. I thought this was more of a
okay.
I didn't,
no, that's fine. You don't have to have slides.
And so I was sent a few questions. And I don't know if these are things that you all have already covered or not, but I can actually copy them into the chat and see if that's what.
Yeah, we haven't discussed, we have not had the discussion about what you're talking about today. So I did go over the agenda, and I said you would be talking about like managing safety with mobile crisis or around mobile crisis. Okay. So yeah, but we haven't touched on it just yet.
Okay. And so, and I just put them in the chat so everybody can see them. But talking about, mental health care professionals and their concerns or questions about safety. And about warning signs in terms of when law enforcement might need to be included. So, I think when it comes to that first issue, really you want to be as data-driven as possible. It sounds as if this is pretty decentralized in terms of how it's being implemented, which is often the case. And I think Southern states might be even more guilty of that than some of the other ones. As a Florida native who's transplanted to Georgia. But I think that one of the things that's most useful when you have something that is anxiety or fear provoking is to counter that with facts, right? And we know that as a whole, the person in mental health crisis is much more likely to be the one who's harmed than the person who's responding to them. And I think that as we roll this out, to the degree that counties can be incentivized, encouraged, equipped, supported around gathering that data, that's going to be the most effective tool you're going to have in terms of being able to reassure people about how this looks. The other reason I think that data is so important is that when you do have those outliers and something happens, because just law of averages, something at some point somewhere probably is, that data is going to help you in terms of using that in order to have a sense of, what calls may be more likely to need backup. And the other reason I think that data collection is going to be important is because I truly believe it's going to be an outlier. It's easier for you to make inferences from it or understand things from it if you have multiple data points. So you're going to need multiple counties kind of reporting this back to you so that you know what to do with that or what to make of it. When it comes to warning signs, if you look at mental health conditions as a whole, bipolar disorder, if somebody's manic, and substance use disorder are the ones that have, relative to other mental health conditions, more of a risk of violent or aggressive behavior. Now, that doesn't mean that that's going to be what that person has, but diagnostically, those are two things to kind of look out for. I will say that to the degree you're able to kind of have it be a rolling response. So even if you have mental health professionals and you have law enforcement officers backing them up, that it's like truly a backup and they're not going at the same time. Because you can imagine if you right now had a group of counselors and police officers show up at your door, that would be quite overwhelming for you. Think about somebody in mental health crisis and what that would be like or what that would look like for them. So when you do have reason to believe that you should be more concerned, maybe the person has a history of violence or somebody's already been hurt, or there's a weapon involved or something like that, to the degree that it's possible, sort of rolling people out. I did have a question for you all. The behavioral healthcare professionals that are doing the dispatching, are they people who are already part of or that work in that community providing services on a sort of ongoing or outpatient basis, or is this another team or another group of folks altogether?
Yeah, we have a pretty diverse mix of people here on the call. So when you say dispatch, the people who are dispatching, are you referring to the call at the call center stage?
Well, I'm sorry, the behavioral healthcare professionals that are actually going to the site.
Oh, okay. Like
the co-responders?
Yes.
I can jump in. I can jump in sort of in the, because there's essentially two things kind of going on. Folks at the mobile crisis hubs that are being dispatched, those teams are, it's essentially the hubs will be dispatching anybody that accepts Medicaid. So it'll be all the public teams as well as private teams that accept Medicaid. So they'll be sort of very community-based, I would say. Whereas then cities or counties that have a specific co-responder program, that some of them, that's where there's going to be variability. Some of them it's, very much kind of embedded in the community services boards. I think other ones, it is like a new employee, a new team, working as part of that. So I think there's a lot of variability there. Whereas on the teams being dispatched once you call 988 and coming from the hubs, I would say Virginia's taking a pretty broad approach. It's not just like all, one new team type or anything like that. It's pretty, like you said, pretty decentralized.
Hey, Lisa, having Medicaid is not a factor in dispatching from the mobile hub, though. Certainly on the public side with, and they will be varied individuals depending on whether they're single response or co-response or, dual response with licensed and certified crisis staff, along with some QMHPs and peers, trained peers.
Yeah, sorry about that, y'all. I was thinking about when private providers join, that's usually the pathway in, but yeah, that was not true.
Gotcha. So another thing that I think is helpful, and it may be hard to get data about this as you're going through, but to the degree you're able to have people that are familiar with that community's cadence, the frequent flyers at your CSBs, your ERs, that are either part of that response or that are available to be a resource to the people who are, I think that's going to decrease your chances of something going awry as well, right? If you work at a community service board or at a psych ER, Mr. Johnson and what sets him off and when he normally comes in and that sort of thing. And that I think would be reassuring for both the provider whose energy and demeanor the patient is going to pick up on, but it's also going to be important for the person in the community if they see somebody they already know, trust, that they associate with the hospital or that sort of thing. I'll give you guys an example. The state hospital in Atlanta, some of the patients call it the Regency, it's Georgia Regional Hospital. But there's a certain transference they have to the hospital, right, and to the institution. So if you're able to have those folks that are either involved, training corresponding with them available, I think that that will be helpful too. I can't give you a study that shows that, but just sort of what we know about people and what makes them comfortable and transference. And I think those are things that could be helpful. Any questions or other comments about that before we go to the next one? Yeah.
What we're doing in Virginia Beach is pretty interesting. We actually have Wednesday morning meetings every week. We were having 3 times a week when we first went live, just to identify any concerns. But it's almost become a treatment team meeting for exactly what you were saying, Ms. Benson. We're talking about the people that are calling very often, and we're collaborating. Virginia Beach is collaborating all together, and between the PSAP, the regional call, determining how many calls are being made from this individual and trying to identify, what the best method is for sending our follow-up individuals with resources for that individual to try to reduce those incidences of calling the PSAP. So we are talking about that's the wonderful thing about the MOUs is it allows us to share information, so we can get detailed as to what the individual needs. So that's the way it's being handled in Virginia Beach right now, and it seems to be really, really effective.
That's fantastic. And, that's the sort of thing that often under fee-for-service models, you have a hard time getting reimbursed for. So people don't want to have all their clinicians tied up in a meeting, but those meetings are invaluable. So to the degree that your MOUs or your setup allows you to do it, I would highly encourage everybody to replicate what they're doing, because it also is going to foster trust between all the people that are doing the work, which is also going to have dividends for everybody. So yeah, that's great. Any other questions or comments before we go to the next one? And if they're not explicitly providing funding support for components like that, that's certainly something to advocate for, and to share your experiences of what you're doing at Virginia Beach and how that's helpful, because you want it to be sustainable, right? You don't want it to be this one-off thing. You want it to be something that's supported financially so that you can do it on an ongoing basis.
I think something that's really good that Todd just mentioned too is it's not just the behavioral health folks that are getting together to discuss those individuals, but they're bringing in all of their partners, such as 911, which not only is it kind of best practice to do, but it's also going to work to kind of reduce some of those negative outcomes through 911, and maybe more immediately get those people transferred over to 988. So really good. Thanks, Todd, for sharing.
So the second one was law enforcement feels reluctant, resentful about having such a high volume of behavioral health calls, but are also skeptical about behavioral health care professionals' ability to respond on their own. How can we resolve this tension? So I think that actually goes along with what you just talked about, right? You get to know each other, you trust each other, you have a better sense of who should go where. But I think, part of it is this is new, right? This is new for all of you. There's a degree to which tension is going to be there, and parts of it are going to be uncomfortable, and just accept that. That's part of the process of doing something great and new, is that you're going to have moments of doubt and where you're having to figure it out. And you all just went live, how long ago?
December 1st.
Yeah, the tension's gonna be there for a minute. Just understand that's part of doing the kind of frontline innovative work that you're doing. So yeah, that's gonna be there to a certain degree. But I think that the biggest thing again is gonna be data and people having those points of information, because the way that our minds work sometimes is when something is unknown, we think of the worst possible scenarios. Then when it actually shakes out, we have something to counter that narrative we built in our head. But right now, you guys don't have anything to counter it with, really, because it's so new. But I think that, once you're gathering that data and you can show, we've done this for 6 months and no mental health care providers have been injured, that's going to be really reassuring for people. But you do want to make sure you have that data so that you can reassure them. What additional skills could we train behavioral health professionals with that might make law enforcement feel more comfortable? I don't think that you want to I think the beauty of this model is that you're respecting the different contributions that each has to these crises and to these calls. So I don't think it would be a good use of your time or resources to make mental health professionals more law enforcement-like. If they need that backup, they need that backup. It may be that some recognition around acute intoxication, if you are sending out mental health professionals who don't have that experience. So, if you're plucking people from garden variety outpatient clinics who may not have ER experience or CSU experience or that sort of thing, then maybe either pairing them with somebody who has that kind of experience or having them get that kind of experience, I think from a clinical standpoint would be helpful. Recognizing things like acute intoxication, having experience with de-escalation, things like that. But there isn't anything that I would say from a sort of law or legal or self-defense standpoint that I think would be important to teach them. Do you all have a sense of the and it's so decentralized you may not, but do you have a sense of the sort of clinical backgrounds or experiences of most of your mental health responders?
I would say from Virginia Beach's standpoint that we have a pretty good idea of what the background is and what their qualifications are. We also run trainings together, but one thing I'd like to add is Virginia Beach, and I used to be the CIT coordinator in Norfolk. One of the things that we found that was really, really beneficial was bringing clinicians into the CIT. We would save seats for the clinicians. It really bridged a lot of communication gaps, especially when we started off with like the ES supervisor and the people working with emergency services. I mean, in that 40 hours, they built relationships right there, and it really, the cohesion really started to elevate, especially when we started bringing in the local area colleges as well. We brought in Norfolk State, ODU, and their law enforcement for their grounds, and it just, we could see the jurisdictional issues start to dissipate. They were collaborating so much more effectively, but it definitely strengthened the relationship when it came to having the clinicians in there showing their credibility in front of the law enforcement and understanding what basically the law enforcement type of culture and terminology that they're using. It was, especially with the role plays and things like that, it was incredibly beneficial for building those teams.
Yeah, and I think that I think a through line here, right, is that it's relationship and rapport, right, which is what we know as clinicians, and there's ways that we have to develop that with people we're collaborating with too. And my mom's a retired probation officer / cop, and I know a lot of the folks in that field go into it for a lot of the reasons we go into mental health. It looks really different. But there's a lot more in common than people might realize. And once you sit with each other in meetings and in CIT, those sorts of things come together. So, anytime you can get people in the room and interacting, not in the middle of a crisis, it builds that foundation so that when you can trust each other more.
Yeah, that's a really good point. I also would like to ask, well, I guess part of the framing for that question also is not necessarily taking into consideration and understanding law enforcement definitely does have a role, and when needed, we do want people to request that backup and have them on scene for safety purposes. I think it's more on like the de-escalation kind of in situations where law enforcement does not need to be involved, but kind of the fear that folks might have in situations that could be de-escalated, don't need a law enforcement person there present, and potentially just because of people's past experiences with law enforcement, it could be escalated once they arrive on that scene, right? So just looking at the toolbox that our clinicians can have on how they can de-escalate situations and really understand that line between, hey, it's time to call for help right now, like this is, red flag here, versus, okay, let's see if we can back up and, get the situation under control before it's needed to escalate to that next level.
Yeah, and that's where I think those community partners are really, really helpful too, right? You know, if you have the autistic 17-year-old whose grandma really calms him down, that's really helpful to know, right? Because if law enforcement shows up because they're not backing down and they're getting more agitated, they're frustrated because they can't communicate, and that's not going to be what you want it to be. And so things like those treatment team meetings and having people from the community be part of it is going to be really, really critical. If you look at mental health conditions as a whole, particularly when you think about the more severe mental illnesses, a lot of times the focus is on you know, the axis one or the mental health symptoms, the paranoia, the psychosis, the mania. But you have a loading in that population also of like speech problems and language disorders and communication difficulties. And so not only do they have the symptoms, they also have communication problems. And then you put on top of it this really emotionally charged situation. And so there are things that a law enforcement officer may do where they're feeling as if the person's not, you know, responding, or they're being defiant, or they're not following orders. But it could be that, you know, following orders requires you to hear it, comprehend it, process it, then have the control and the agency and the executive functioning to carry out the order and understand in context, which for a lot of us is pretty easy, but for a lot of the people who are overrepresented in these calls, that may be a tall task. And so, you know, having those community supports, I heard somebody mention peers, but you have a lot of informal peers, right, in the community. You have the coach people listen to or whoever, right? So trying to have a sense of those folks too, the natural supports as we call them, I think is going to be key. And Mr. Lindstrom, I think, were you raising your hand?
Yeah, I was. I think our mobile crisis responders will all go through a training course. They've already had a lot of training, and those that are doing child are going through a training course now. There's an adult course that'll roll out. All of it, besides some of the legal issues, focuses on de-escalation. I know all of our employees have to annually certify in nonviolent crisis intervention, which involves de-escalation and timing and distancing and all of those kinds of tools that we can use in that process. The one thing I would say is those of us who, those staff who will be working in pairs with law enforcement for the more traditional co-response team, the respective components do need to do some cross training, at least with respect. Mental health needs to understand basic police procedure. They need to understand basic police culture, and the reverse would be true of the officers, so that they understand what to expect of each other in the field, and when to play and when to take the primary or secondary role in that process. And those are things that we plan to include in our training of co-responders.
Yeah, and that's great. And I think that intentionality around who takes the lead when, or what are the indicators when that needs to happen, is super important. And sitting down and thinking that through before you're out there, like trying to make a decision on the fly is critical. There was something that you said that made me think about something. You know, we have this thing in medicine, in morbidity and mortality, right? Where if there's a death or if something goes wrong, you get together and you go through the case. And it's not about blaming anybody. It's about taking that and learning from it. And again, and thinking about that data, right? You have the numbers data, like the stats, but then I think that if you do have a case where de-escalation doesn't work, or maybe the backup should have been called earlier or whatever, really taking advantage of those incidents, and having some sort of qualitative, right, data that comes out of that, and trying to sit down and understand. And sometimes you can have the best protocols in the world, and sometimes things are just gonna go a lot. But taking those as opportunities too, I think is gonna be really important, especially in these first few months as you guys are sort of working this all out. And then suggestions for planning tools, brainstorming methods, or systems that would help the committee think through these issues. And you know, what I would say there is that I think that given how localized a lot of this is, part of that's really going to depend on the resources they have available to them and what they're comfortable with. You know, when I'm teaching my residents and we're talking about treatment plans, I tell them the best treatment plan is the one that's clinically indicated and that the patient is able and willing to follow. So you don't want to be too directive if it's something that's not going to resonate with that community or that is not readily accessible resource. So encouraging them to be methodical and intentional and think about it before people are in the field is one piece of it. But I think that you want those communities to be informed by their strengths, their resources there, and sort of implement things accordingly, and then encourage them to gather that data so that they can be sure of what's working for them and what's not.
If I could, I'm with the police department down in Danville, so a little bit from a police perspective. I'm not really seeing tension between the law enforcement and we've got a great partnership here with our Down Pennsylvania Community Services, and we do not have a full co-response out, but they do have mobile crisis, and we're doing a lot of things together, always available. But the bigger issues have been, at least from the law enforcement side, open to mental health experts coming in and taking over as much as possible, but just the funding and the filling positions and availability, because we've had great planning, but the reality is now we've got to fund this and actually have some coverage. So in the meantime, we have to continue to 100% train our people in de-escalation, CIT training, and keep expanding every type of training we can, because I guess they're a little, at least from the law enforcement side, a little skeptical when I talk to them that this is going to happen on a broad scale, statewide, and truly have 24-hour coverage, other than it always seems to revert back to law enforcement. It ends up being we're here 24 hours a day. And so I'm having that trouble. I'm not really selling it, but inside of law enforcement, they just got that skeptical that it's just not going to get funded and it's not going to get rolled out like it really needs to. So I've had no tension between us and mental health professionals at all. I think everybody's on the same board there, but there is a lot of, I guess, that just doesn't think it's going to get where it needs to go. I do deal with that.
Yeah, and I think that there's some experience-based mistrust there, right? Where, you know, states sometimes start things and they don't go all the way through, and it happens everywhere. And if you've been in public, you know, service long enough, you've seen those cycles happen. So I think that makes perfect sense. You know, I will say from a mental health perspective too, though, and I don't know how recruitment has gone with providers being willing to go do this work, that sometimes there's a stigma around people who may be criminal justice system involved, or who are the folks getting these 911 calls. And so I think to the extent you're able to partner with, you know, training programs, get people early exposure to this kind of work, to working at the law, medicine, mental health interface, that would help to destigmatize this work and this population. You know, I've worked in correctional facilities in one form or another for a good chunk of my career, and a lot of times people are like, "Oh my God, you're going to jail! I can't believe it!" And I'm like, "It's the same people in the public sector clinic. Like, it's the same population, and I have more security at jail than I have in clinic. Like, it's really." But people like have these ideas in their head, and so, you know, as this rolls out, especially if it rolls out statewide, you're going to come up against the same mental health staffing shortages that every other system and service line does. And so trying to do that work and get to people early, I think it's going to be critical from a pipeline perspective.
That's great. And I think you've kind of hit on some areas that at future meetings, and even when we're kind of working with the different areas as they're working through planning and implementing, we have some things that we can kind of work off of and talk about. Yeah, so I guess I know we only have you for a short period of time, so I want to give everyone an opportunity to ask any last questions that they have for Dr. Vinson.
And I'm putting my email in the chat too, so feel free to reach out if I can be helpful.
All right, well, it doesn't look like we have any lingering questions, but I definitely want to thank you, Dr. Vinson, for joining us. And I hope to have you again to have some other sessions to think through some topics, I guess some difficulties or struggles we're having as we're going through this process of implementation. But we really appreciate you stopping by and having this chat with us.
Yeah, thank you all for doing the work. I know it's a heavy lift, so thank you for your service.
Yeah, the heroes are here on this call.
Absolutely.
So the ones in the trenches.
Absolutely.
So thank you. For everyone else that I do want to circle back and see if there were any other lingering questions about legislation or impacts. I hope we still have Josie here with us because I don't. Yes, she is, because I'm not the best at answering all the legislative questions. John, it looks like you have one.
Yeah, I would just, just one general comment first. And I think what we're trying to do is create a system that's not one and done. And so creating that continuity and those warm handoffs and that whole crisis array so that we don't just see that isolated person and then we don't expect to see them again. So I think that's really important for us to all keep in mind and might work in our favor, countering some of the barriers that Dr. Vinson raised, and they're all true. Lisa, this question really is for you, and I had not heard anyone say, and maybe I'm just missing a detail of the legislation, but I had not heard anyone say that the first five localities still didn't have to be fully implemented until next year. And we're operating as though our soft implementation will just be built on in that process. My question would go to how would any of the legislation, I guess we got to get a confirmation on what that delay might mean, but clearly there are going to be challenges with integrity of data during this initial rollout because of the database having yet to be completely built out, which is instrumental, and some of the CAD requirements that need to be adjusted to really truly have high quality data from the PSAPs. Because currently, even in Richmond, they're doing a very manual process to track those calls now and record the call volume. Is there going to be any do you imagine that there might be any getting back together again to think about data quality and targets for that data collection?
Yeah, I would say yes. I mean, the timing of this meeting was good in some ways, but then also, it's depending on if one of these goes all the way, we'll probably need to kind of pull this group together before August. I think, before August to sort of, for those of you that have worked with DBHDS a lot, usually we think about implementation in 3 phases. So sort of like with the beginning of phase 2 being more of a soft launch and then phase 3 being full implementation. And so, the way that the dates are switched around, we would really need to, it would change the state plan to a certain extent. And I don't know how exactly we would go about figuring that out, but definitely.
And are you thinking then about, I think you've planned 2 stakeholder meetings annually now, and this being the first one for FY for 22. Are you thinking then maybe an August stakeholders meeting to bring us back together again for updates?
Yeah, so that would be that was already the plan. If the legislation makes a big change, I don't know if that would be perfect, but that's still the plan as of right now.
Thanks.
Hello, everyone. I have a brief question, I guess as a piggyback to John. I think back last September, we had heard that there would be a data group convened, and it being almost March now, we haven't heard anything since then. So just curious where we are with that.
I can take that one. So you know, with the decisions about everything going through the call center data platform, we have really, you know, sort of tied ourselves to that implementation timeline. And there definitely were some delays there, but they have launched they have sort of a PSAP group that they're meeting with to try to get some of the technical pieces going. And then I think that they have I don't know if if the CTAC group is going to start or not, but yeah, we need to get clear about how are we going to pull these pieces together? Because yeah, you're right. We're getting, with it being March, and you know, a lot of time has passed, and some of that is just truly we decided that we only wanted one data system, and so we kind of are, you know, we've tied our projects together that way. But I think you're right that we should.
Lisa, we're still going to have separate data from PSAPs, so because the PSAPs aren't entering information in the data platform. And so the important information that I think if we can get reliably reported will be their call volume and how they code the calls, and how they fit the protocol. If it is a call that's diverted to the call center, there will be a rich amount of data ultimately available in the data platform for those diverted calls. But depending on how your protocols are structured, that might miss some level 3 calls, and it would miss all of the level 4 calls, based on the way we've configured those protocols. So to me, I'm very comfortable with having 2 data sources, as long as we have a process of reasonably extracting the information.
All right, were there any other questions? It looks like we are at time, so I did prepare like a last slide, but I'll just kind of go over that without sharing that. So as always, you can reach us at marcusalert@dbhds.virginia.gov is the email address, or you all have my direct email address from sending this invitation. You can always reach out to me and send any questions, whether it's law enforcement, PSAP, or behavioral health. Dallas and I work closely together, so I can always share that information with him. Also at the next meeting, I just want everyone to be prepared. We have having these 6-month meetings. There's a lot of information to try to cram into the agenda. So next time we'll probably send out some reading materials just ahead of time, so everyone can kind of, we can come to the meeting and actually have more action rather than jamming 6 months of updates all together. The calendar invite has been sent for the next meeting already. So as previously referenced, that's going to be in August. I can definitely send out the slides to you all. So thank you, Todd, for asking. I'll send out the slides. This recording or this meeting is being recorded, so it'll be posted to the DBHDS YouTube page as well. So thank you all for joining us, and we will see you in August. And again, feel free to reach out for any additional information. So thank you all very much, and enjoy the rest of your day.